Protein C and S are two anticoagulation proteins that inactivate coagulation factors 5A and 8A in the coagulation cascade. This means they act like brakes on coagulation, limiting clot formation and preventing clots from growing too big. So, when either of these proteins is deficient, it leads to a hypercoagulable state, meaning a person is at increased risk of developing a clot that could block blood flow. The most common places for such clots to develop are in the deep veins of the legs and in the vessels that carry deoxygenated blood through the lungs. Normally, protein C and protein S are two of many proteins or enzymes that regulate the complex process called hemostasis. This is where a solid clot forms in the flowing liquid blood to plug the defect in a damaged blood vessel. It has two steps. Primary hemostasis involves the formation of a platelet plug at the site of injury, and secondary hemostasis involves coagulation, where several clotting factors come into play to form a fibrin mesh over the platelet plug to reinforce it and form the blood clot. The main role of protein C and protein S is to prevent excess coagulation or fibrin formation during secondary hemostasis. Protein C and S prevent excess coagulation by interacting with several other proteins involved in a complex system of checks and balances. So it starts with a protein called thrombomodulin, which is on endothelial cells that line our blood vessels, and together with thrombin, they form a complex that also includes protein C and protein S. When protein S joins this complex, it activates the proteolytic site of protein C, which cleaves and inactivates active factor V, a cofactor for factor 10 in the common pathway, and factor 8, a cofactor for factor 9 in the intrinsic pathway. The factor V degradation product also binds to this complex and further enhances its ability to cleave more active factor V and active factor 8. By inhibiting both the intrinsic and common pathway, less fibrin is produced and coagulation slows down dramatically. So, in people with protein C and S deficiency, the thrombin-thrombomodulin complex can't cleave and inactivate factors 5 and 8. This increases circulating factor 5 and factor 8 levels and tips the scale toward coagulation, putting them at increased risk for thrombosis or developing blood clots. This usually occurs in the deep veins of the legs or in the pulmonary arteries that carry deoxygenated blood from the heart to the lungs. There are two types of familial or congenital protein C and S deficiency. Both are inherited in an autosomal dominant manner. Type 1 disease is when there's not enough protein C or S, so there's a quantitative defect. Type 2 disease, however, is a qualitative defect, because enough protein C or S are made, but the proteins don't function properly. There are also acquired forms of protein C and S deficiency, like impaired production as seen in patients with liver disease or in patients taking warfarin, also called Coumadin. Another cause is excessive urinary loss of these proteins, which can happen in people with nephrotic syndrome. Protein C or S deficiency is commonly asymptomatic, but symptoms arise when a venous thromboembolism develops. That's when a clot forms, usually in the deep veins of the leg, and then parts of the clot can break off and travel to other parts of the body. Symptoms of venous thromboembolism include pain similar to a muscle cramp and swelling in the affected leg. If a clot breaks off and travels to the lungs, there can be signs of respiratory distress like pain with inhalation, fast heart rate, and a fast respiratory rate. If clots get lodged in the cerebral vessels, which usually occurs in a vein, it could cause headache, numbness or weakness in the face, arm, or leg, confusion, or slurred speech. Clots can also occur in veins in the abdomen, potentially causing signs or symptoms associated with injury to the liver, spleen, or intestine. A more serious presentation is neonatal purpura fulminans, which is when a newborn with protein C or S deficiency suffers massive arterial and venous thromboembolisms with hemorrhagic skin necrosis. Finally, with protein C or S deficiency, there can be warfarin-induced skin necrosis, which means tiny thrombi can form in the blood vessels of the skin, causing skin necrosis. This is a risk for people taking warfarin, especially in large doses, without an overlapping rapid onset blood thinner such as heparin or low molecular weight heparin. Protein C and S deficiency is suspected in people with a strong family history of coagulation disorders, especially those who suffer from recurrent venous thromboembolisms and experience their first thrombotic event before age 50. Protein C or protein S deficiency is also sometimes suspected when a venous thromboembolism develops in an unusual site, like the portal, mesenteric, or cerebral veins. Diagnosis is made by identifying low levels of protein C and S in the serum. Since warfarin can lower the levels of protein C and protein S, it is very important that a patient does not take warfarin for at least 2 to 4 weeks prior to being tested for protein C or protein S deficiency. Alright, as a quick recap. Protein C and protein S deficiency refer to two separate hereditary hypercoagulable disorders that involve the inability to inactivate factors 5 and 8 in the coagulation cascade. Most people present with venous thromboembolism, where a blood clot of the leg veins or lung circulation is most common. Initial treatment of venous thromboembolisms is the same as it would be for patients with normal protein C and protein S levels. However, identifying a low protein C or protein S level may, in some situations, impact long-term decisions about anticoagulation therapy.